The neck. Here we see just basically a simplistic overview of what the neck actually looks like. As we know, the neck is composed of many different tissues. We have the bone that actually provides the structural rigidity for the neck, but then we also have a lot of ligaments, muscles, and also vessels that are in charge of a lot of things like supplying the brain with blood or oxygenated blood and returning the deoxygenated blood back to the heart. So we see a lot of things. So on this image, the book kind of confuses a lot of people as to why would they throw this image in there. It really doesn't have any labels, no beneficial diagnostic usage. However, upon closer examination, we see that we have this area here. And so what this area is, if we assume that we're going through this actually at an equal plane, and so you should be seeing a lot of symmetry between the body. We see no abnormal area here on the left, and so this person has a mass, which probably is a lymphoid type mass at the base of the neck. And if we look even further, we see that it's kind of almost causing some degree of stenosis for the artery, which should not be present. So things like this are what you have to look at for the neck. Very, very interesting to see how all the structures actually perform and work together to utilize the movement for the neck. So if we first begin by looking just simply at the neck, we see the organs of the neck are attached to one another by connective tissue. They are located primarily in the anterior and middle portions of the neck and include the pharynx, larynx, esophagus, trachea, salivary glands, thyroid gland, and cervical lymph nodes. So, as we can see, there are many different types of tissues that are viewed in the neck. And so we just get a little simplistic overview of the pharynx, larynx, esophagus, trachea, and those are the structures that we typically consider being in the neck. But then we have all of these other associated structures as well. So if we begin simply by looking at the pharynx, we see that it is a funnel-shaped fibromuscular tube. So keep that in mind. It's fibromuscular, meaning that it's part fibrous and part muscle. And so that's how it helps to utilize both respiratory and breathing functions. It's 12 centimeters long, and it acts as an opening for both the respiratory and digestive systems. And so that is very unique because it provides a passageway for both air and digestive functions. And it extends from the base of the skull and ends inferiorly as the continuation of the esophagus. So where the pharynx ends, it becomes the esophagus. And it's divided into three sections. The nasopharynx, which as the name implies, has something to do with the nasal passage. Oropharynx, which oro implies mouth. And laryngopharynx, which is around the larynx. So just by simply breaking down these words, we can actually demonstrate where these things are. So if we begin by looking at the nasopharynx, it's the most superior portion of the pharynx, and it is an extension of the nasal cavities with which it shares the nasal mucosa. It has a respiratory function to allow for the passage of air from the nasal cavity to the larynx. And so, once again, nasal means nasal. And so, it's going to be associated with the superior portion of the pharynx. The uvula is a process on the posterior edge of the soft palate, which is still part of the nasopharynx. And the roof and posterior wall of the nasopharynx is a collection of lymphoid tissue known as the pharyngeal tonsils. They have a protective immune function of initiating early activation of specific defense mechanisms. And we have the Eutugian tubes, which connect the middle ear to the nasopharynx. So, one thing that you need to remember is that the tonsils have an immune function. And the Eutugian tubes here are what are responsible for draining the ear into the nasopharynx. And it's when this passageway becomes inflamed and blocked that typically you get ear infections. And so it's very important to keep the Eutugian tubes open. You've heard probably of people having tubes put in their ears, and that's typically what we're talking about is you're opening up the Eutugian tubes and keeping them open to prevent people from having prolonged ear inflammation, which can damage the auditory functionality. The oropharynx is a posterior extension of the oral cavity. It extends from the soft palate to the level of the hyoid bone, and it's separated from the larynx by the epiglottis. And so we'll look at the epiglottis in terms of CT. And it contains the palatine tonsils, which are situated on the base of the tongue. The palatine tonsils are what? When you hear someone having their tonsils removed, this is it. This is tonsil removal here, which keep getting inflamed and then basically cause prolonged sore throats. And so because of this, you remove the palatine tonsils. Going back to the epiglottis, we see that what the epiglottis actually does is it keeps food from going down into the trachea. And so it's kind of a protective function for the trachea, which when you're swallowing, it closes off the trachea so that basically the food goes down the esophagus. So laryngopharynx, as the name implies, laryngo, meaning at the larynx, and it lies between the hyoid bone and the entrance to the larynx and the esophagus. It contains, as the esophagus, or it continues as the esophagus at the level of the cricoid cartilage of the larynx. And although sometimes becomes confusing, it'll make more sense as we actually look at this on CT, and you can actually see where the hyoid bone is located and where the larynx, and so it'll kind of put everything into perspective. The important thing to remember here is this point. Along either side of the larynx are two depressions or cavities termed the piriform sinuses or recesses, and they're in charge of diverting food away from the entrance of the larynx so that it continues into the esophagus. And so basically what they are, when you see them on CT, it's going to look like a gutter type system to where it kind of funnels everything into the esophagus and keeps everything away from going down the trachea. It's important to have this because even, as we know, even the most minute particle that's swallowed and goes into the trachea can actually cause disastrous implications. If you were to get an aspiration pneumonia, this aspiration pneumonia could go and go and go and flourish, and basically you could ultimately die from this. So it's very important that we dissuade any food from going down the trachea if possible. Continuing with the larynx, we see that the bony skeleton that surrounds and protects the vocal cords is commonly called the voice box. The larynx begins at the laryngopharynx and continues to the trachea and marks the beginning of the respiratory pathway by allowing for the passage of air into the trachea. So what the larynx is in charge of is air only. And so where the laryngopharynx becomes the esophagus, the larynx is going to become the trachea. And it is in charge of simply air. It consists of an outer skeleton made up of 9 cartilages that extend from approximately the 3rd to the 6th cervical vertebrae. Keep that in mind, 3rd to the 6th. and it's connected one to another by ligaments that are moved by numerous muscles. Three of the cartilages are unpaired and include the thyroid, epiglottis, and cricoid cartilages. The three paired cartilages are the arytenoid, the corniculate, and the cuneiform cartilages. Really, we're not going to focus so much on the 6 cartilages here, but just know that those exist, but we're not going to focus much on those at all. The inner structures of the larynx include the false and true vocal cords and the epiglottic folds. Resulting swelling of the epiglottis because of the bacterial or viral infection can be very dangerous, which is called acute epiglottis. And so basically, if we break this down, acute epiglottis means that you have inflammation of the epiglottis, which allows it not to function properly. And so where it would only kind of cap off the trachea when you're swallowing, it actually would cap off the trachea all the time, and you would die simply because you couldn't catch your breath. This condition can result in closure of the glottis, suffocation, and so because of that, you definitely do not want this to happen. So it's very important that proactive means be taken if this were to happen. This is why you would see patients have a trach or emergency trach, because they're clotting. This is basically clotting off, and so you have to get below this level, and so that's how a trachea or tracheostomy would work. And so here's a simplistic overview. Pretty simple in general. We have the patient being here. We have a sagittal view, and so as we can see, we have the sella turcica here. We have the sphenoidal sinus, which means that this area here is the sphenoid bone. We have the forehead, or the frontal bone here, and just posterior to the bone, or inside of the bone, we have the frontal sinus. Those are demonstrated to varying degrees on patients. And just below that, we have the nasal bone. And then we get into basically this area here. So we have the nasopharynx, and then we have the uvula extending down, and then we have the oropharynx, the epiglottis here, which allows this to be the laryngopharynx, which is not highlighted here. And then we have the trachea, the esophagus, the larynx, and that's pretty much it. Also know that we have the tongue here, the mandible, and the hard palate. Those are things that we typically would want to remember, because the tongue and the mandible and the hard palate actually play a role in mastication, which is the chewing up of the food so that you can break it down once it reaches the stomach. So that's very important. But basically, one thing that I want you to take away from this is that the esophagus is posterior to the trachea. I know this gets a lot of people confused, and there's really no need for that, because if you're having trouble with keeping which is more anterior to the trachea or the esophagus, because that will become very essential once we actually get into looking at actual CT images. But if you're having trouble keeping them separate and which one is anterior and which one's posterior, then think of it this way. When a person is going to have a tracheostomy put in, they don't have to cut through the esophagus and work their way around it so that they can get to the trachea. But the trachea is what they reach before they hit the esophagus. So if you keep things in that perspective, then it becomes a little more clear as to which one is which. And here we have an actual CT sagittal image. We see that it's almost mirror to what we saw before, but not quite, because things never look the same way that we actually see them on drawings in terms of CT. It's usually not as cut and dry. But we do see the Celaturska here. We have the sphenoid sinus. Right here. And then we do have the inferior, middle, and superior nasal conchae, which kind of all culminate into this one area where we have the nasopharynx. The nasopharynx is just above the uvula. Once you get past the uvula at this level, then it becomes the oropharynx. Once it goes past the epiglottis, then it becomes the laryngopharynx and the larynx. And so what we're looking here is the trachea, and the esophagus is sitting just posterior to it. So this would be the larynx here. And this would be laryngopharynx there. We also continue down into the trachea, and we don't actually see visualization of the esophagus here. We see the tongue. We have the mandible and the hard palate here. And that's pretty much it that we need to recognize from this image. It will become more clear as we progress through our lecture for this. As we can see, this is an axial image, and it's not as easy to demonstrate things as one might imply. We have the uvula. Notice how it's kind of just projecting inward, and that's typically what you're going to look for, this inward projection. And because you can still see the uvula, this means that this is the nasopharynx. Here we don't see the uvula, we don't see an inward projection, and so we have pretty much a smooth structure here, which means that we are at the oropharynx. Also, we see the mandible demonstrated here. And that's pretty much it for this image. As you can see, the delineation between oropharynx, nasopharynx, laryngopharynx becomes kind of skewed. It's best demonstrated on a sagittal image. As we can see here, everything has really kind of become skewed. We have the oropharynx, we have the epiglottis, and notice how the epiglottis is kind of doing this shape here. We have the vallecula, and we're at the level of the hyoid bone. Also, we have the internal jugular vein, and we have the internal carotid artery and the external carotid artery. That will become essential to recognize once we near the end of the lecture, but for the moment, it goes 1, 2, 3. So your external is going to be most anterior, in the middle is going to be the internal carotid, and then your large outer or posterior portion is going to be the internal jugular vein. So as we look at this, it's kind of very difficult to really discern where we're actually looking at. But we do see several things. We have the pituitary gland sitting in the sella turcica here, the mandible, the masculine air cells, the parotid gland, which we will discuss later bilaterally. We have the piriform sinuses, and this is what we were talking about, kind of looking like gutters. See how they're kind of flared out, and they kind of give the appearance of catching everything and kind of bringing it back in. And we do see the thyroid gland labeled here, but we're not going to get into it on this image because it's kind of a hard thing to track, so just kind of mark this one out. This image we have the piriform sinuses, which once again we have the larynx. But notice how the piriform sinuses kind of just have this appearance of diverting things away from it. We have the thyroid cartilage here. So this once again is a review. It's the same image basically that we've already looked at, but let's once again kind of go over this. We're going to have sella turcica, sphenoid sinus, so we're going to have middle, inferior, and superior nasal concave. It's going to bring us into this area here at the posterior portion, all the way down to the uvula, and that's going to be the nasopharynx. Then we have the uvula, we have the hard palate, we have the tongue, mandible, then we have, let's go back to the uvula. And then once we pass the uvula, we have this area here, which is oropharynx. Then we have the epiglottis, which is where this arrow is pointing, which is going to kind of cap off the trachea and allow food to go into the laryngopharynx and into the esophagus. Here we have the larynx, which is where the arrow is pointing, and then the larynx becomes the trachea, as we can see implied here. The esophagus is really not demonstrated, seeing as how it's posterior to the trachea, but we assume just posterior to the larynx is the laryngopharynx, and then on down it becomes the esophagus. So it pretty much mirrors the same layout that the trachea and larynx have, only that you add pharynx to the end of laryngo. And so That's pretty much how this image actually pans out. Uh, One key that I really can give you in terms of looking at anatomy like this is that find you a blank image, something like this, and just kind of go through and label the image yourself and see if you can do that. And if you can, then that provides you an excellent indication that you're on your way to really being able to understand how the anatomical structures lie. Once again, here is an axial image, and we're focusing on the thyroid cartilage here, and we have larynx, this area. We have the piriform sinuses there, and we're not going to worry about the epiglottis because I feel that that's very hard to distinguish where we're actually looking at there. This one is a little more indicative of where the epiglottis actually is. We see that we have this line running here, which is the epiglottis. We have the oropharynx here, which would basically mean that we're getting ready to see the laryngopharynx and the larynx as well, but we're still at the level of basically the chin, as we see the mandible here. And then we have internal jugular vein, internal carotid, and external carotid here. Also, we have the submandibular gland, which is bilateral on both sides. And basically, as the name implies, submandibular means that we are almost below the mandible, and that's where these glands reside, which if we refer to this image over here, then we see kind of where we're scanning through. We see that we have the epiglottis here, here's the esophagus, here is going to be where the trachea is going down, and we're looking at this level here of the oropharynx, and then we're getting ready to go into the laryngopharynx. Here's another image. We basically have thyroid cartilage here, and notice how this calls it the remiglottis, but we're not going to worry about really the remiglottis as we're going down into still the trachea. And so we're going to say that this is larynx or trachea. But notice that there are these areas here. And here. We're kind of coloring these points in that are kind of looking like they're causing an indentation of the larynx or the trachea. This is the vocal cords. This is at the level of the thyroid cartilages. So very important to actually see these and see what they actually look like. Okay. We saw what the thyroid cartilage looks like, and we can go back and see how it kind of looks like almost a triangle. Something like this. Well, that's going to become essential to looking at what the cricoid cartilage is. Notice how the cricoid cartilage is just pretty much surrounding the larynx. We have the larynx being the dark center portion, and the calcified area around the larynx is the cricoid cartilage. Here we have an image that says that the vocal cords are closed, and we see that we have thyroid cartilage here. And then notice that we don't have any air going down, so this is the vocal cords that are closed. So that brings us to the esophagus and the trachea. The esophagus and the trachea allows for the transmission of food to the stomach and air to the lungs. The esophagus is a muscular tube that extends down from the laryngopharynx to the cardiac orifice of the stomach. So keep in mind, the esophagus goes from the laryngopharynx to the cardiac orifice of the stomach. So the esophagus goes a very long distance. It begins posterior to the cricoid cartilage, then descends through the thoracic cavity between the trachea and anterior longitudinal ligament of the vertebrae. It enters the abdominal cavity through an opening in the diaphragm termed the esophageal hiatus to meet the stomach. And so when you hear that you have a hiatal hernia, that's typically what we're talking about here. It has herniated through the hiatus or the esophageal hiatus. There are two narrowed areas or sphincters of the esophagus, which are the esophageal and the cardiac sphincter. The esophageal sphincter is situated at the entrance of the esophagus and functions to prevent air from entering the esophagus. It would be a bad thing to have air entering the esophagus all of the time because you would have rapid bowel distension. Things just wouldn't work out very well. The inferior or cardiac sphincter prevents reflux from the stomach into the esophagus. So it's essential for you to keep these two sphincters in mind and what their functionality actually is, because without them, life would simply not exist. Because if you had tons of reflux, you would basically, over the course of time, cause scarring of the esophagus and probably lead to esophageal cancer due to the fact that you're having healing and breaking down of the tissue structures over and over and over again if you had no cardiac sphincter. If you didn't have an esophageal sphincter, you would continuously dilate the bowel with air, and it would probably definitely cause overdistension and possibly cause bowel wall damage simply because of overextension or distension of the bowel. The trachea, on the other hand, is considered the airway of the body and extends from the larynx to the lungs and lies immediately anterior to the esophagus. Keep that in mind once again. It's anterior to the esophagus, not posterior, but anterior. It's considered an elastic tube. The trachea is reinforced by many C-shaped pieces of cartilage that maintain an open passageway for air. We saw the cricoid cartilages, and that's those C-shaped pieces of cartilage that help to maintain and keep it open, as we saw before. So we have the cricoid cartilage here, which is kind of helping keeping the trachea open. We have the trachea, and notice how it fits neatly posterior to the aortic arch and runs and actually bifurcates into right and left main stem, and then further branches. The esophagus, on the other hand, actually continues down and meets the stomach. We have the esophageal hiatus, this is where the diaphragm is. And this passageway allows the esophagus to actually meet the stomach. We don't really see the sphincters here, but I believe on another image we actually will. So if we begin up a little higher, we see that we've probably just entered into the trachea and the esophagus. And notice that we have the trachea here, and we have what looks to be some cartilage around the trachea. But just posterior to the trachea, we have the esophagus. Many times you're not going to be able to really distinguish the esophagus just simply because of it being or looking like it's closed, because you're not in a persistent state of swallowing, but you are in a persistent state of breathing. And so you're always going to see the trachea, or usually you're going to see the trachea filled with air, whereas sometimes you're not going to see the esophagus very well demonstrated. So that brings us to the salivary glands. Many people often discount what the salivary glands actually do and how important they are, but they're vastly important. The salivary glands produce and empty saliva into the oral cavity by way of ducts to begin the process of digestion. Each pair of salivary glands has a distinctive cellular organization and produces saliva with slightly different properties. And so basically, why you have different salivary glands is quite simple. Your body is breaking down varying degrees of substances, and because of that, one gland cannot simply break down all types of substances. So there's 3 different glands that secrete different forms of saliva, which help to break down food. See that there are 3 large paired salivary glands: the parotid, submandibular, and sublingual. So the parotid is going to be to the side. Submandibular is and sublingual. I'm sure that we've all heard of medication being sublingual, and this is below the tongue. The largest of the pairs of the salivary glands are the parotid glands, which are situated in front of the auricle and wedged between the ramus of the mandible and the sternocleidomastoid muscles. And we'll actually see this in terms of what it looks like on CT. It extends inferiorly from the level of the external auditory meatus to the angle of the mandible. Their appearance differs from that of other salivary glands because of the amount of fat that they contain. And so they're going to look very fatty. They're going to have the appearance of what you would see fat on CT. And that's something to keep in mind so that you know that you're looking at the parotid glands. The submandibular glands border the posterior half of the mandible, and they extend from the angle of the mandible to the level of the hyoid bone. The sublingual glands are the smallest of the salivary glands and lie under the tongue on the floor of the mouth. So here is the location. We have the sternocleidomastoid muscle running here. Then we have what we presume to be the angle of the mandible, somewhere situated there. So this means that this is the parotid gland. The sublingual gland is just like we assume it to be. Here's the tongue, and directly below the tongue is the sublingual glands. The submandibular glands, we have the mandible, and it's situated directly below. So this is basically what it looks like in terms of CT. We have the ramus of the mandible will be here, and then we have sternocleidomastoid muscle here, here. And so if we look in between the ramus of the mandible and the sternocleidomastoid muscle, we have this weird looking structure here. Notice how if we assume that this is fat out here, notice how it has an appearance more like fat than it does of muscles, like the sternocleidomastoid or this muscle here. And so that's typically what we're looking for. This, pretty much all the parotid glands that I've ever seen have this appearance to them in terms of CT. Also, as we're looking at this, we have this indentation here, which means that this is probably oropharynx, and this is the uvula. Okay, here's a little differentiation of the parotid gland. We see that we have the sternocleidomastoid muscle kind of running here, here, and we have this area here and here. It's a little better demonstrated on the right side than it is on the left, but notice the appearance once again. This structure here. This is the parotid gland. Notice that we're at the level of C1, C2, C3, C4, and so we're slightly above C1 when we begin, and we end about the level of C2 for the parotid glands. Also notice that we have the internal jugular vein being very, very large in contrast to enhanced structure. Very hard to not be able to distinguish where the internal jugular actually is due to the size of it. Here we have the tongue. And we're down a little farther. We're actually getting into almost the sublingual / submandibular glands. But based on the location, we say that it's probably closer to submandibular. And we have this area here on both sides. This is the submandibular glands. Notice here that we're in oral pharynx as well. So that brings us to the thyroid gland. The thyroid gland is an endocrine gland located at the level of the cricoid cartilage. They consist of two lobes that are joined together anteriorly by the isthmus. In the axial plane, the thyroid gland appears as a wedge-shaped structure hugging both sides of the trachea. It excretes the hormones thyroxine, which is T4, triiodothyronine, which is T3, and calcitonin, which affects almost every cell in the body. So any abnormalities in thyroid functionality can really demonstrate the importance of this gland, because other functions of the body will not work simply because of that. Thyroxine and triiodothyronine stimulate cell metabolism and are essential for normal body growth. Calcitonin lowers the blood calcium level, promotes bone formation. So basically, you have an abnormality with being able to produce calcitonin, and you're going to have higher amounts of calcium in the bloodstream, and basically you're going to have low bone formation. Bone is always being broken down, and it's always needing to be rebuilt. And so because of that, if you don't have any calcitonin, you're not going to be able to build where bone is injured. Also involved with metabolism of calcium as well as phosphorus are the parathyroid hormones, or the PTH, which are produced by the parathyroid glands. The parathyroid glands are located on the posterior surface of the thyroid lobes and are usually 4 in number. So here we have an overview. We have the hyoid bone situated up here. Below that we have the thyroid cartilage. And then below the thyroid cartilage we have the cricoid cartilage. And then directly below the cricoid cartilage we have thyroid. And notice how thyroid actually has almost a wing type of appearance. And then below that we have the trachea, aortic arch, superior vena cava, things like that. Also we have the internal jugular veins here. Then we have the common carotid. So looking at it in terms of CT, we see that we have the epiglottis, very apparent. We have the oral pharynx. Then we have the laryngopharynx. And then this means that we have the trachea here. And then we have this structure here, which is the thyroid gland. Notice that we have thyroid cartilage. And then we really don't see a differentiation between that and the coracoid cartilage. Coracoid cartilage is really not demonstrated very well in this image, but it's just below the thyroid cartilage. Also, we have the internal jugular on both sides. We have, let's see, the sternocleidomastoid muscle. Here. And I believe that's it for this image. This one kind of demonstrates everything much better. We have the coracoid cartilage here. It says tracheal cartilage, but we're around the level of the coracoid cartilage, so tracheal or coracoid would be adequate for this. We do have thyroid kind of molded around the trachea. Have the esophagus just posterior. We have common carotid here and here, and the internal jugular here and here. So pretty much know this image. So lymph nodes. Cervical lymph nodes. The neck has an extensive lymphatic network containing more than 1/3 of the body's total number of lymph nodes. So as you can see, the neck is very important. There's tons of lymph nodes there. Typically as many as 75 lymph nodes are located on each side of the neck alone. So basically 150 are located on each side of the body. It's pretty interesting. Lymph nodes are clustered in regions throughout the vessels of the lymphatic system. The lymph vessels carry fluid from the interstitial spaces to the regional lymph nodes that filter the lymphatic fluid of harmful foreign particles before being emptied into the venous blood supply. In the cervical region, nodes are grouped along the lower border of the jaw, in front of and behind the ears, and deep in the neck along the larger blood vessels. And so that's why when you get sick, if you feel and under your mandible, sometimes you can feel lymph nodes there, depending on what type of inflammation and if you've actually had swelling there. We're not going to actually worry about the location of the lymph nodes because I feel that that is almost impossible to actually distinguish where all these lymph nodes are. But the important thing to remember is that there are a lot of lymph nodes. You're not going to be responsible for this image, but just know that there are a lot of lymph nodes for just this region of the body. So the muscles. Numerous muscles are located within the neck. Each muscle can be difficult to identify individually because the margins seem to blend together in cross-sectional images. This section of text addresses only the largest and most significant muscles of the neck region. So basically your book kind of informs you that there are so many muscles, and basically they're just going to focus on the large and most significant muscles of the neck, and that's I feel is the best way to kind of go about this. So muscles within the anterior triangle, the neck is frequently divided by the sternocleidomastoid muscles, or the SCM, into two areas called the anterior and posterior triangles. Everything anteromedial to the SCM is considered part of the anterior triangle, Everything posterior to the SCM is considered part of the posterior triangle. The SCM is a broad strap-like muscle that originates on the sternum and clavicle and inserts on the mastoid tip of the temporal bone. So as you can see, it's a very large muscle, very long muscle, and it functions to turn the head from side to side and flex the neck. Muscles within the posterior triangle. The muscles of the posterior triangle include the trapezius, splenius capitis, levator scapulae, and the anterior, middle, and posterior scalene muscles. The trapezius muscle is a superficial muscle located on the posterior portion of the neck, and it acts to elevate the scapula. So let's know the functionality here. It originates from the occipital bone and spinous process of C7-T12 to insert on the clavicle, acromion, and spine of the scapula. So once again, it is a very large muscle. As you can see, C7 to T12. Basically, it's very important. Located just anterior to the trapezius muscle is the splenius capitis, which arises from the lower cervical and upper thoracic vertebrae to insert on the occipital bone and acts to extend the head. That's something to keep in mind. It's going to be responsible for extending the head. The levator scapulae muscle is located in the posterior lateral portion of the neck. It arises from the transverse process of the upper four cervical vertebrae to insert on the vertebral border of the scapula and acts to raise the scapula. So, levator scapulae is going to be responsible for raising the scapula. And so here we see the trapezius muscle. So we're going C7 to T12. We also have the deltoid muscle, which is very important for shoulder functionality. We have levator scapulae muscle, which is here. Here we have the sternocleidomastoid. As we can see, it goes, the mastoid is situated somewhere right here, and attaches to the mastoid and then runs to the sternum. Here we have the trapezius muscle once again. I believe that's it for this portion. The carotid arteries. Now, the right common carotid artery arises from the brachiocephalic artery posterior to the sternoclavicular joint. The left common carotid artery arises directly from the aortic arch. So remember we looked at the chest and how the brachiocephalic trunk, brachiocephalic artery, the right, is actually responsible for giving rise to several arteries, and one of them is the right common carotid. The left, on the other hand, branches straight from the aortic arch. The common carotid arteries lie medial to the internal jugular vein and bifurcate into the internal and external carotid arteries at approximately the level of the thyroid cartilage, which is C3 to C4. So keep that in mind. Thyroid cartilage is at C3, C4, and that's also where the common carotid arteries bifurcate into internal and external carotid arteries. The internal carotid artery ascends the neck almost in a vertical plane to enter the base of the skull through the carotid canal of the temporal bone. The internal carotid artery has no branches in the neck, but branches in the head to supply blood to the orbit and the brain. So the internal carotid artery is very important, and it's going to be in charge of supplying blood to the orbit and brain. As the external carotid artery ascends the neck, it passes through the parotid gland to the level of the temporomandibular joint, where it bifurcates into its terminal branches to supply blood to the face and neck. So the external carotid artery is in charge of supplying blood basically to the face and the neck. That brings us to the vertebral arteries. The vertebral arteries begin as a branch of the subclavian artery and ascend the neck through the transverse foramina of C6 to C1, where the arteries enter the foramen magnum and join to form the basilar artery. So basically, they run separate up the neck, and then once they enter the foramen magnum, they kind of combine and form the basilar artery. The vertebral and basilar arteries supply blood to the posterior aspect of the brain. So that brings us to the jugular veins. The internal jugular veins drain blood from the brain and superficial parts of the face and neck. They're typically the largest of the vascular structures in the neck. The internal jugular veins commence at the jugular foramen and posterior cranial fossa and descend the lateral portion of the neck to unite with the subclavian vein to form the brachiocephalic vein. And so basically, it's kind of all of this in reverse. The internal jugular veins begin in the head, and then they work their way down, and then basically they unite with the subclavian vein to form the brachiocephalic vein. And so sometimes it's kind of hard to keep everything straight, but when we actually look at it on CT and see how everything kind of combines, it will hopefully make more sense. The carotid sheath. The carotid sheath is a compartment composed of cervical fascia that encloses the common and internal carotid arteries, the internal jugular vein, and associated lymph nodes in the vagus nerve. So here we see a drawing which will hopefully kind of put everything in perspective. So we have, this is T1, this is C7, C6, C5, C4, C3. Okay, so we need to keep that in mind. Hyoid bone. Then right below the hyoid bone is the thyroid cartilage. We have the aortic arch. And then we have brachiocephalic artery, common carotid, and then subclavian here. So we have the brachiocephalic, which actually branches off into the right subclavian, and also the right common carotid. So the right common carotid actually goes up, as does the left common carotid. We reach the level of C4 to C3. That's important to remember. C4 to C3 is where we actually get internal and external carotid arteries. As the name implies, the internal carotid artery actually is going to go up to the brain, and the external is actually going to go out into the face. And so we see the bifurcation here. Also, we have the vertebral arteries, which are somewhat labeled, but they're kind of difficult to discern. But we have the vertebral artery going up through the foramen, coming off of the left subclavian and the brachiocephalic or the subclavian for the right side, working their way up, and then we have right vertebral, left vertebral, and we're getting ready to become the basilar artery. This kind of puts everything a little more into perspective once you remove the bones, and you can see how everything actually is. We see we have the aortic arch here. Then we have the right brachiocephalic, which this is right subclavian, but that is wrong. That is, the subclavian is right here. This is right brachiocephalic. Here. And so we have the right common carotid going up, the right subclavian going down. We don't see the subclavian really coming off the aortic arch, which we would presume would be here the left subclavian going down. So we do see the left common carotid as well. The left common carotid kind of works its way up, as does the right. We're at a level of C3, C4, and we see the bifurcation. What's curious about looking at this is we can get a generalized idea of external versus internal. Notice how external is actually going outside, and the internal is actually staying inside. And so that's something to kind of keep it straight, is that the external is going to go out and kind of branch all over the face, and the internal carotid arteries are actually going to keep on going up and kind of become more compact. Also, we see that we have the vertebral arteries, which we have where I'm tracing now is the left vertebral artery, and we have the right vertebral artery. They come together, and then they form the basilar artery. So here is a picture of an axial image, and we have the internal jugular, then we have the common carotid artery here. We've not branched actually yet. So we have the internal jugular, common carotid, and we're not going to worry about the anterior jugular vein, but we do see the external jugular vein being here and here. And even though it's really not labeled, I do believe that this is probably the vertebral artery, but we really can't be sure because we're not seeing other images to really suggest this. Okay, this image kind of gets a lot of stuff involved. We have the parotid gland here. We have left and right vertebral arteries. We have the external carotid here. And we have the internal carotid. Let's go back. This is actually the internal carotid. This is the external carotid here. And basically what you're looking for is symmetry. If you were to draw a line from here to here, you would want the left and right side to pretty much mirror each other. And in terms of vessels, unless there's some gross abnormality that has caused everything to become shifted, you're typically going to see the symmetry so that you can basically apply one thing to another, and so that you know that if you can really demonstrate where an artery is on one side, you should be able to carry that over to the other side as well. Here we have right vertebral. This is probably left vertebral. Have the parotid gland. Sternocleidomastoid muscle. Other parotid gland on the left side. Looking at the oropharynx. Then we have the external carotid artery. And then we have the internal carotid artery. Once again, notice how the internal carotid arteries are inside and the external carotid arteries are going towards the outside. We're not going to really, well, yeah, let's demonstrate the masseter muscle, which is, as the name implies, it's going to be responsible for moving the jaw to a certain extent. I believe that's it. We're not going to worry about the medial pterygoid muscle, so just kind of mark that out. So if we look at these two images, one's just slightly a little different than the other. And so we see that we have parotid gland once again. We have right and left vertebral arteries. We have the internal carotid, and then we have the external. This is probably internal carotid. We have the tongue here. Uvula. Okay, this image, we have the epiglottis. Oropharynx. We have external jugular, internal carotid, external carotid. Internal jugular, internal carotid, external carotid. We don't really see the vertebral arteries here. We have the sternocleidomastoid muscle on both sides. Okay, we have the piriform sinuses. We have the internal jugular veins, and notice how the right is larger than the left. On many patients, you're going to see usually one being more predominant than the other, based on just probably several demographics. It could be which side of your body you favor more than the other. But you have the common carotid artery. We're getting ready to see the bifurcation, because we're at the hyoid bone, should be actually seeing it. We have the vertebral artery here, which is kind of difficult to see, so don't worry about that. We have the submandibular gland, sternocleidomastoid muscle, and that's pretty much it. This one, notice that we are basically at the level of the thyroid cartilage. We're seeing it here. And we're seeing the vertebral arteries, internal jugular, common carotid, and we're getting ready to see the bifurcation. Here we are at the level of the thyroid. We have internal carotid, or not internal carotid, but internal jugular. And then we have common carotid here. We have the trachea, esophagus, sternocleidomastoid muscle, which has kind of rotated from being on the side of the body to the anterior portion. We have the trapezius muscle here.